Bismillahirrahmanirrahim. Dear students, Assalamu alaikum. Today we will discuss Neuro of Thermology. First of all, there is cortical blindness. The most common cause is bilateral occipital lobe infarction. It results in unilateral infarction results in contralateral homonymous hemianopia. In hemianopia means the half side of VN is gone, and homonymous means in both eyes either temporal visual field or a nasal visual field is lost. The central macro region is spared in occipital lobe infarction due to dual blood supply. The most common cause is head injury, and the less common cause is neoplasm involving the occipital cortex. VN and VL fields are markedly decreased in both eyes, bilateral involvement, usually with sparing of macula. But sometimes there may be complete visual loss with no light perception. That means total blindness. Papillary responses are normal as papillary pathway courses from lateral geniculate body to pretectal nucleus and is not controlled by cortical metals. Now the giant cell arteritis. In giant cell arteritis, there is constant headaches, which may be unilateral or bilateral. In the temporal area with prominent vessels, which are tender, it is a temporal artery which shows pulsation, which is often palpably thickened. It is thickened and tender. There may be intermittent claudication of the jaw, that is pain on jaw movement. The syndrome is self-limiting, but may lead to blindness due to vascular occlusion. Then we have migraine. Migraine is very common problem. 10% people have migraine. There is periodic, typically unilateral, throbbing or boring headache, accompanied by nausea, vomiting, mood changes, fatigue, and visual disturbances. There may be zigzag aura of flashing lights, and it is relieved by dark surroundings and sleep. If you ask the patient that what you do in case of headache, he will say that I go to a quiet room, a dark room, and I feel better. It is known to recur at regular intervals. Now the pathogenesis of migraine. The pathogenesis is divided into three phases. The first is brainstem degeneration. The second, vasomotor activation. in which arteries both within and outside the brain may constrict or dilate. The third is activation of cells of the trigeminal nucleus caudalis in the medulla, which is the brain's pain processing center of the head and the face. Fourth, the serotonin receptors are being held responsible for triggering the neural origin of migraine. Now, the clinical features of migraine. It is also called half-sided headache. आधे सर का दर्द जिसे कहते हैं. It affects 10% of the population and is characterized by half-sided headache. The usual site of headache is the frontotemporal region. It is usually unilateral, but can be bilateral. Mostly it is unilateral. It affects all ages with highest incidence in children and young adults. It is more common in females, but among children, girls and boys are equally affected. And if you ask, is there any other family member affected by migraine? The answer will be usually yes. There is family history is common. Now, if you take history of past history, there may be past history of car sickness or cyclical vomiting as a child. Migraine in children may manifest as recurrent abdominal pain and malaise. The episodes may start after awakening and are generally relieved by sleep. Also, if they take some analgesics like Panadol, etc., it is relieved. The duration of each attack varies from 6 hours to 2 days. Migraine is known to be associated with or precipitated by menstrual cycles, puberty, birth control, or hormonal pills. Any stress can lead to migraine. Foods containing tyramine or phenylalanine, such as vintage cheeses, wines, chocolates, cashew nuts, nitrates or nitrites. Coffee. Coffee is a cause, a risk factor. Taking coffee can lead to migraine. So we tell the patients not to take coffee and less take of tea. The other precipitated factors are monosodium glutamate, alcohol, fatigue, lack or excess of sleep, as I earlier told you, any stress or bright lights. Migraine is associated with visual disturbances. It is characterized by visual disturbances associated with classical migraine and include zigzagging flashing lights. Zigzagging flashing lights is very typical of classical migraine, also called fortification spectra. There is blurred vision or a visual field defect lasting 15 to 30 minutes, usually preceding the headache. पहले जो है वो zigzagging flashing lights आती हैं और 15-20 मिनट बाद हेडेक शुरू हो जाती है. It's very typical of classical migraine. The migraine may often be preceded by an aura or an inexplicable sensation of an impending migrainous attack. Patients may experience photophobia during the headache phase. Neurological deficits such as hemiparesis may occur. Now, what kind of neurological deficits can occur in migraine? There are of 4 types: cerebral, which can be motor, sensory, or visual. The neurological deficits can be ophthalmoplegic. There is ipsilateral paralysis of one or more extraocular muscles, more common in children. The retinal deficits, sudden monocular visual loss without flashes may occur. So it is not necessary that there is a zigzag aura before migraine. It can even occur without flashes. The visual loss may occur without flashes. The basilar artery migraine, bilateral blurring of vision or blindness, diplopia, vertigo, gait disturbances, formed visual hallucinations, and dysarthria. Now we come to the differential diagnosis of headaches. Differential diagnosis of migraine. This includes all other causes of headache. A common migraine, headache without aura. Remember that common migraine is more common and there is no aura before the headache. The classical migraine is less common but is typical with headache with aura. Acephalic migraine and complicated migraine. There can be arteriovenous malformations, mass lesions with cerebral edema, and an elliptiform seizure focus. The seizures can cause similar headache. Now we come to the differential diagnosis of a headache. Remember that whenever we come to the differential diagnosis, we must make a list of life-threatening causes. Common causes, life-threatening causes, and in eye ophthalmology, the vision-threatening causes. So these include life-threatening or vision-threatening causes include malignant hypertension, raised IOP, intracranial infections like meningitis, brain abscess, subarachnoid hemorrhage, epidural or subdural hematoma, the structural abnormalities in the brain can be a tumor, aneurysm, or AV malformations. The giant cell arteritis, acute angle-closure glaucoma, and ocular ischemic syndrome. Other causes include tension headache, cluster headache. In cluster headache, there is headache with mild ptosis and herpes zoster ophthalmicus and Tolosa-Hunt syndrome. Now these are some locations of different types of headache. In hypertension, there is occipital headache. In stress, there is bitemporal headache. In migraine, it is half-sided headache. And in sinusitis, the sinuses are tender. Now we come to the treatment of migraine. Avoid all agents or stressful events known to trigger attacks. Like I already said, coffee should be avoided. Appropriate spectacles. If there is refractive error, it should be corrected, as it may also be causing headache. As there is nausea, so anti-nausea medication and analgesics are the mainstay of treatment, such as aspirin, paracetamol, ibuprofen, naproxen sodium, nimesulide. These are analgesics commonly used as soon as possible after the onset of headache. There is also some role of prophylactic medications like propranolol or amitriptyline. These can be taken prophylactically. The more potent therapy with one dose of 2 milligram of ergotamine in recurrent and resistant cases can be used. However, it is known to cause many complications and is contraindicated in elderly individuals or those with cardiovascular, cerebrovascular, renal, or hepatic diseases, and pregnant patients. Now the infections. Meningitis. Meningitis is an infection involving the pia arachnoid resulting in the collection of inflammatory exudate in the subarachnoid space and cerebrospinal fluid. If the brain parenchyma is also affected, it is termed meningoencephalitis. If parenchyma is affected, it is called meningoencephalitis. Encephalitis is for parenchyma. Now, it is either due to a systemic infection. The infection may have come from systemic sources with organisms such as meningococci, pneumococci, viruses, etc., or as a result of spread from neighboring infective focus, close range infections. For example, the paranasal sinuses, middle ear, or from a distant septic focus with hematogenous spread. Now, the meningitis presentation and causative organisms. A fulminant acute infection which progresses in a few hours, most commonly due to Streptococcus pneumoniae, 50% of the cases. You must remember this commonest cause, as it may come in MCQ. Neisseria meningitis, 25% cases. Group B streptococci and Listeria monocytogenes. The viruses include enteroviruses, that is polioviruses, arbovirus, HSV1, HSV2, HIV, mumps, cytomegalovirus, measles, influenza A and B, rubella, and varicella zoster virus. A subacute infection that progresses over several days. A chronic meningitis which involves as a neurological syndrome and persists for more than 4 weeks due to partially treated suppurative meningitis, Mycobacterium tuberculosis, Lyme disease, among the bacterial pathogens, secondary or tertiary syphilis. I have seen some young females with tuberculous meningitis at a previous hospital. They present with oculomotor nerve palsies like third nerve or sixth nerve palsy, and on MRI we see various foci of exudations, and it is treated with anti-TB treatment along with systemic steroids. The meningitis clinical features, the classical clinical features include fever, headache, and neck stiffness. There is altered sensorium, nausea, vomiting, and photophobia. The seizures and the features of raised intracranial pressure, A typical skin rash, neck rigidity is pathognomonic. Rarely papilledema may develop. Now the meningitis, the characteristic sign is the widely open palpebral aperture, often associated with very infrequent blinking. There is paralysis of sixth nerve, as I already told you, usually unilateral, and is more common than that of third nerve. Sixth nerve is more common. The pupils vary in size, showing meiosis, that is constriction of pupil, in the early stages, and mydriasis, that is dilatation of pupil, when coma sets in. There may be complete amaurosis with normal fundi and pupillary reactions. Optic neuritis and post-neurotic atrophy from secondary hydrocephalus. Other infections, they include cavernous sinus thrombosis. It is very serious condition. Can develop as a result of suppurative infections in the danger area of the face or orbit. Presents with fever, headache, retroorbital and frontal pain. Restriction of extraocular movements, that is ophthalmoplegia. Chemosis, proptosis, bulging of the eyes, ptosis, drooping of the eyelid, absent corneal sensations, and hypoesthesia of the face along the ophthalmic and maxillary divisions of the trigeminal nerve. There are on fundus examination tortuous, that is maybe dilated retinal veins, papilloedema, and loss of vision due to exposure keratopathy, or optic nerve involvement due to raised intraorbital pressure, or secondary to septic vasculitis and ischemia. Other infections include subdural empyema. Empyema means collection of pus in the subdural space. Epidural abscesses, collection of pus in the extradural space. In brain abscess, collection of pus in the brain parenchyma with necrosis. I have seen patients with cavernous sinus thrombosis. They usually come on wheelchair or carrying trolley. Usually they are not very conscious, and there is ophthalmoplegia. Early detection and treatment is very important in cavernous sinus thrombosis. Then syphilitic infections, congenital. The lesions develop after the 4th month of gestation, when the fetal immunological system begins to develop. Acquired infection, this is sexually transmitted disease, can also be acquired by exposure to infected blood. The neurosyphilis may be asymptomatic or symptomatic. CNS, central nervous system invasion by Treponema pallidum, the cause of syphilis, can occur within the first few weeks of infection. The symptomatic neurosyphilis can present as meningitis, usually less than 1 year of acquiring infection, meningovascular disease usually presents 5 to 10 years after the first exposure, or paranochiamatous involvement generally persists at 20 years, and tabes dorsalis at 25 to 30 years, or a combination of the three in different degrees. Now the eye signs in syphilis. This is very important. Papillitis, papilledema, papillitis, inflammation of the optic nerve, papilledema, swelling of the optic nerve, post-neurotic atrophy of the optic nerve is frequently found, about 13% of each, and is usually bilateral. The visual field effects are very common. The third, fifth, and sixth nerves can be paralyzed, and least frequently the sixth nerve, the fourth nerve. The characteristic pupillary signs include the so-called spinal meiosis, the Argyll-Robertson pupil. We used to remember a mnemonic for Argyll-Robertson pupil, that is accommodation reflex present, ARP. There is loss of light reflex, but there is accommodation reflex is present. It's called Argyll-Robertson pupil reaction. Inequality of the pupils and distortion of the pupillary aperture. The paralysis of the extraocular muscles and primary optic atrophy. Now the very important topic, demyelinating diseases. Multiple sclerosis, it is considered to be an autoimmune disease with a relapsing, remitting, or progressive course, pathologically characterized by focal inflammation, demyelination, and gliosis or scarring. In multiple sclerosis, most patients, that is 90%, initially experience a relapsing, remitting clinical course with episodes of neurological dysfunction, separated by intervals of months or years. Neurological deficits can be spinal, cerebral, etc. The course and the prognosis of multiple sclerosis. There is selective demyelination with relative sparing of the axons is the hallmark of this disease. But partial or total destruction of axons with irreversible neurological damage may also occur. The genetic predisposition, MS occurs between adolescence and middle age, twice as common in females than males. As is other autoimmune diseases, we see they are more common in females than males, like thyroid disease, myasthenia gravis, etc. They are more common in females. So this can come as an MCQ for you. Now the clinical manifestations. There are neurological signs, as we earlier said, limb weakness, 35%, sensory loss, 37%, paresthesia, 24%, and optic neuritis, 37%. These are the commonest symptoms. So you must remember the commonest symptoms of multiple sclerosis. Diplopia, ocular double vision, vertigo, and ataxia, difficulty in coordination, are relatively less common. There is a specific Lermet sign in multiple sclerosis in which there is a transient electric shock like sensation shooting down the spine into the legs, and it is induced by neck flexion. If you flex the neck, there will be electric shock like sensation shooting down the spine into the legs. There is gradual visual loss, facial palsy, seizures, and impotence are rare manifestations. Prognosis. Eventually, most patients experience progressive disability to a greater or lesser extent, with only 20% having no functional limitation. Now, this is very important. The ophthalmic manifestations of multiple sclerosis. Lesions in the visual pathways often occur in multiple sclerosis in 50% of the cases. There is usually unilateral retrobulbar neuritis. That means retrobulbar means behind the optic disc in orbital part or other parts of the optic nerve, excluding the optic disc. The visual field may clear up entirely. The visual defect may clear up entirely, but may be followed by irregular field defects. Some degree of optic atrophy usually develops. Retinal venous sheathing is sometimes found in multiple sclerosis. Also, there can be pars planitis, vitritis in multiple sclerosis. Inflammation of vitreous can be there. Nystagmus occurs in 12% of cases. Presence of a relative afferent papillary defect is fairly common, and to a lesser degree, inequality of the pupils. There is paralysis of the extraocular muscles are less frequent. MS is the commonest cause of bilateral and unilateral internuclear ophthalmoplegia, that means the restriction of eye movements in young people. Other demyelinating diseases include neuromyelitis optica, also called Davick disease, acute multiple sclerosis, acute disseminated encephalomyelitis. Congenital nystagmus, as you see in this patient, there is to and fro movement of the eyes. Now, the optic neuritis intracranial tumors. First of all, we will discuss papilledema. As you see in your right side diagram, there is blurred disc margins due to disc edema, and in other diagram you see sharp disc margins, which is a normal optic disc. Edema of the optic disc or nerve head due to raised intracranial pressure, local mechanical compression, ischemia, and inflammation. Now, the clinical features of papilledema, as you see in this diagram, there is blurring of the disc margins and elevation of the optic disc. So, the elevation of nerve head. Retinal vessels may appear to drap over the elevated disc margins. There is blurring of the disc margins, peripapillary nerve fiber layer opacification. There can be hemorrhages as well at the optic disc margin. Hyperemia and dilatation of the disc surface capillary network. There is retinal venous dilatation. As you see in this diagram, the veins are dilated. Peripapillary hemorrhages, as I already told you, there can be hemorrhages at the disc margin, exudates or cotton wool spots, which are also called soft exudates and are caused by axonal ischemia. The retinal or choroidal folds or macular edema. This is another diagram. As you clearly see, there are blurring of the disc margins, venous dilatation, and elevation of the optic nerve head. The main cause of optic disc swelling is blockage of exoplasmic transport. There is elevated cerebrospinal fluid pressure, exoplasmic stasis, swelling of the optic disc, and secondary vascular changes at the disc surface. Now, the pathology can be interpreted from this diagram. There is increased intracranial pressure, which results in exoplasmic stasis and optic disc swelling and subretinal fluid. The optic nerve sheath distension resulting in choroidal folds. The exoplasmic stasis results in venous obstruction and edema, which leads to retinal hemorrhages and nerve fiber layer edema or exudates. The optic disc swelling results in axonal compression, hypoxia, and gliosis, finally ending up in optic atrophy. Now, the etiology of raised intracranial pressure. There can be intracranial tumor, brain abscess, thrombosis of the cavernous sinus, as we have already discussed, is a very serious condition, and other intracranial veins, aneurysms, subarachnoid hemorrhages, pseudotumor cerebri, also called idiopathic orbital inflammatory disease, and hydrocephalus. Malignant hypertension, grade 4 hypertensive retinopathy. Now, the differential diagnosis. Ischemic optic neuropathy produces profound sudden VL loss. This is differential diagnosis of papilloedema. So there can be ischemic optic neuropathy, especially anterior ischemic optic neuropathy. The papilloedema may be simulated in 3 conditions. Now, it's also called pseudopapilloedema. You may be asked the causes of pseudopapilloedema, in which there is no papilloedema, but it looks like it is papilloedema. The pseudoneuritis or pseudodisc swelling due to drusen's of the optic nerve head. The drusen's may be observed as elevated lesions with blurring of the disc margins, but they are also familial and is typically bilateral, 70% cases. The papilloedema is, remember, always bilateral. Papilloedema is always bilateral. It's not a unilateral condition, but it can occur that in one eye there is optic atrophy due to some other cause. So you will find papilloedema in contralateral eye. However, if there is no such pathology, remember papilloedema is always bilateral. It can come in MCQ as well. Hypermetropia, the congested disc. The eyes is small, the disc is small, and it can manifest as pseudopapilloedema. The refractive error checking can help us in this scenario, like a refractive error of +4, +3, +4. A true optic neuritis involving the optic nerve head, there is papillitis. Papillitis, there is less salivation. Remember, in papillitis, there is less salivation. The optic nerve head is hyperemic, red, very red, but it is less elevated. Prognosis. Essentially, the relief of the intracranial pressure, VN improves rapidly unless the nerves have been irreversibly damaged and papilloedema subsides. The recovery of VN may be faster than the subsidence of papilloedema. Will field should be carefully watched. Disturbance of the circulation. This is very important topic, the ischemic optic neuropathy. In old age patients, there is sudden unilateral VL loss, and with no other symptoms, but there is a you can see blurring of the wrist margins and papilloedema. It is circulatory insufficiency to optic nerve head. The ischemic optic neuropathy can be divided into anterior ischemic optic neuropathy and posterior optic neuropathy, which can be further divided into arthritic, that is inflammatory, and non-arthritic, that is non-inflammatory. The arterial blood supply of the interior part of the optic nerve head is from posterior ciliary arteries. The interior ischemic optic neuropathy, it is most common cause of optic neuropathy in patients over the age of 50 years. Remember, it is the most common cause. So this can come as an MCQ, but it is the most common cause of acute optic neuropathy in patients over 50 years of age. The cause is due to ischemia of the anterior part of the optic nerve head, the involvement of posterior ciliary artery circulation, considered in DD, differential diagnosis of sudden loss of VN, visual field loss always present. Now the etiology, as you see in this diagram, there is also blurring of the wrist margins, and there is optic disc elevation and retinal and optic disc hemorrhages you can see. The etiology of ischemic optic neuropathy is broadly classified into two categories. The arthritic, which is most serious type. Remember, it is the most serious, not most common. Mainly due to giant cell arthritis. It is very serious condition. And the non-arthritic, which is most common. Remember, not most serious, but most common. These two things can come in MCQ, which is the most serious type and what is the most common type. It consists of all other causes than giant cell arthritis. The arthritic anterior ischemic optic neuropathy, you see in diagram, there is chalky white swollen disc. Chalky white swollen disc is typical of giant cell arthritis. An intensely chalky white swollen optic disc is most common ocular complication in arthritic, that is inflammatory anterior ischemic optic neuropathy. In lower diagram, you can see there is a white patch along the supratemporal arcade showing branch retinal occlusion. There is pale, fluffy, ischemic retina. Also occurs as do central retinal vein, central retinal artery occlusions. Now, non-arthritic anterior ischemic optic neuropathy, NION. The risk factors are age. Age is the most common risk factor, remember, over 50 years. Hypertension, diabetes, cholesterol, the disc at risk, like in hypermetropia, there is already congested disc. Sleep apnea, the nocturnal hypotension, not carotid stenosis. The 15% sequential 5 years, 50% no change, 43% improve, and 7% worsen. The age in arthritic ion is over 70 years, and in Nyon it is usually over 50 years. Sex predilection is females in arthritic and no sex predilection in non-arthritic. The preceding systemic features like jaw claudication, headache, scalp tenderness, these are signs of giant cell arthritis. They are present in arthritic and not present in non-arthritic. The preceding ocular symptoms are highly suggestive of arthritic, but rare in non-arthritic. Veal loss is highly suggestive in arthritic and is in 20% cases in non-arthritic. Pain, it is differentiating feature of giant cell arthritis from the non-arthritic anterior ischemic optic neuropathy. It is common in arthritic and rare in non-arthritic. There is second eye involvement. There is 75% within days or weeks, and 40% in months or years in non-arthritic. Second eye involvement is more common in arthritic anterior ischemic optic neuropathy. The disc appearance is typically chalky white swollen disc. It can come in as MCQ. The chalky white swollen disc is a characteristic of arthritic or giant cell arthritis and is sectoral or paler in non-arthritic. FFA fundus fluorescein angiography investigation shows choroidal filling defect and is normal in non-arthritic. The ESR is differentiating feature. It is raised in arthritic. In giant cell arthritis, whenever you suspect in medicine and ophthalmology, you always go for ESR. It is raised, it is arthritic type, and is normal in non-arthritic. So ESR must be done. It is cheap, easily done, available at every hospital. CRP is raised again in arthritic and is normal in non-arthritic. The temporal artery biopsy is done when we suspect arthritic anterior ischemic optic neuropathy and is positive and is normal in non-arthritic. The management, assessment of the circulatory and microcirculatory systems to exclude any form of arthritis, ESR and C-reactive levels. In temporal arthritis, large doses of systemic steroids are mandatory and are gradually tapered off to a maintenance dose. The eye itself should be carefully assessed for raised IOP. The subtle changes such as mild polycythemia or anemia or slight elevation of IOP may impair disc perfusion and precipitate an attack of ion anterior ischemic optic neuropathy. Thank you very much, students. Inshallah, we will discuss in next lecture posterior ischemic optic neuropathy. Thank you very much.